welcome everyone. We are delighted to see such great interest in changing the shape of delivering healthcare in the United States. Many of you know that direct care is not a new concept, but there is a great need to revive the concept. I will start with a little bit of a history. I read recently about the history of insurance companies in the United States, and I found out that before 1800, there was no insurance in the United States, probably not even worldwide. And the patient and the physician were in direct communication and direct contact, and the physician was providing direct care to the patient. In 1850, the first US insurance firm was founded. And at that point, it offered just catastrophic insurance. When people were having an injury, at that point, they will cover just in case of an accident that resulted in an injury, the insurance company will kick in. And in the late 1920s, the insurance companies introduced the hospital and medical expenses. Those things were things that I didn't know, but I wanted to share with you. Since then, we have all witnessed a constant increase in healthcare expenses and also in insurance premiums. And we spend today as a nation, that's not a number that nobody knows, $3.8 trillion on healthcare. And we as a family, we spend about 20,000 every year. And unfortunately, when we talk about specialty care, the access to specialty care and access to physician-driven care more recently is starting to be difficult. And patients are frustrated. Patients, they are frustrated with their increasing costs. They are frustrated with us because we are the interface with the system. And they are frustrated because the prices are not transparent. And sometimes they intentionally delay care because of fear of the cost. And in my journey as a direct care specialist, I was fortunate enough to meet people that already paved the way before me, like Dr. Muto or Dr. Dickerson. But I also met a lot of specialists that were interested in restoring this relationship with the patient, becoming again a physician, not becoming a wheel in that productivity model. And unfortunately, the caveat is always that they are afraid to start or they don't know where to start. So today we have a unique opportunity to speak with pioneers of direct care in the United States. And I would like to introduce you first, Dr. Paula Muto. Paula, you are muted.
Hello. So, first of all, Diana, thank you very much for inviting me and putting this together tonight. So we have to be more and more vocal. I'm just going to start with that. We have to have these conversations beyond the hospital corridors, which we're actually quietly in the hospital corridors because we're not allowed to talk in the hospital corridors anymore. We're, always kind of silenced. The doctors are like sitting here quietly on the sidelines watching as we cannot get the care for our patient, even our own loved ones. Literally, I was just navigating my father-in-law with my husband, who's also a surgeon, last night in our hospital, and having to hear like, well, we can't get a nurse after 7 p.m. It's like, whoa, so after 7 p.m. there's no more coverage for emergencies. And like, this is not a hospital anymore, right? The things have just gotten too far. I just wanted to add to Diana's history on insurance. So she's that one of the things that really has evolved in the last 50 years was when insurance costs got so high, employer-based insurance came into the marketplace after World War II. I don't know if many people might know this, but there was a wage freeze that Truman put into place to keep workers in their factories. So instead of offering higher wages, they offered benefits. And those benefits included those rising costs for health insurance, the Blue Cross and the Blue Shield, which covered the office and also covered the hospital costs. And that was the birth of employer-based insurance. And when you got into the 60s and you were too old to work, or if you didn't have a job, that's where Medicare and Medicaid came from. And the very first Medicare patient was in fact Harry Truman and his wife Bess. They were the first two Medicare patients. So then you kind of fast forward to the managed care world and the insurance companies and the the deregulation of Blue Cross Blue Shield, and the marketplace became competitive. That employer-based health insurance remained very strong. The government-based health insurance, the employers were buying health insurance, and somewhere along the way, the patient got pushed off the table as the one who's purchasing health insurance. And because of that model, we always look back and say, well, we have to please the employers, we have to please the government. It's like, no, what about the patient? And the reason there's so much frustration is because more and more the costs have now shifted right back to the patient. But the transparency isn't there anymore. It's no longer you go to your family doctor, you deliver a baby, they give you a bag of grain, right? That doesn't happen anymore. There's no relationship anymore between the physicians, the value of what the physician does, because there's so many layers in between. I think right now with where insurance is, employer-based health insurance, it's just chaotic. The prices are far exceeding the actual price of care. Insurance, they pay more to their insurance company than they do their doctor. It's a wonderful opportunity to seize the day, say time out, let's put some common sense and actually offer a true competitor in the marketplace. And that is really the exciting part of this, is right, we are going to be competitors with the existing system, the government-based and the employer-based. Guess what, you can buy direct, and you can buy, and we can still be in all those other piles, but you can buy direct, and we need to offer that to patients. And I think that's really compelling right now. And it's I'm glad that you talked about the history of it, because this is a watershed moment in healthcare. Where with digital technology, we can in fact be accessible, we can be affordable, and we can be transparent and let the patients decide what's the higher value.
Thank you, Paula, for making those comments. They are very important. I'm going to say a couple of words about Paula. She is the Uberdocs founder and CEO. She is a graduate of New York Medical College, and she is a practicing vascular surgeon with a solo practice and the owner of Muto Vein Center. And she comes from a family of physicians that are practicing for more than 50 years in Massachusetts. And she created Uberdocs, which is a platform where she has 5,000 physicians, right, Paula?
Yeah, and we're getting there, and more every day.
They are getting, they want to get priority access to the best doctors in a very transparent and affordable price. The next speaker is Dr. Cristin Dickerson. She is the Green Imaging founder. She's a radiologist. She's a graduate of Baylor University and University of Texas Medical School at Houston. And she trained extensively in cancer imaging at MD Anderson. She founded Green Imaging in 2012, and her goal, I will let her to express her goal. Dr. Dickerson.
Okay, thank you so much, and thanks for having me. I kind of wandered into the direct care model almost 10 years ago now. I saw a problem that needed solving in my city, and that was we had 21% uninsured, probably higher than that because we have a lot of Hispanic population that's not documented. And deductibles were rising, and if you're likely not going to meet your deductible in a year, you are a self-pay patient, because what's the economics of healthcare over the last decade? Really early in the last decade, the problem was hospitals acquiring physicians and practices and facilities and aggregating. And the cost of care, if a patient sees a hospital salaried or subsidized physician as compared to an independent doctor, is 3 times greater all the way through the episode of care. Every test they have, every imaging exam, every specialist they see, it's at least 3 times more expensive, but on average 3 times more expensive. And so that was one of the big problems. Now what we're having, early this decade is the mergers and acquisitions, and a lot of it's private equity based, and a lot of that is going on, in the space that we're talking about, even in the direct care space. We've got to be careful that doesn't yet create unintentional malaligned incentives in this space. But what's going to happen there is right now, if we're going directly to physicians and buying care, we've eliminated a lot of the unnecessary middlemen, and we're also creating true competition. If we get back into the space where we're having to feed profit, we're going to be back where we were with the hospital. So we have to make sure that incentives are aligned. We can do it. When we get the insurance companies and the hospitals, out of the equation, there's a lot left over. But we just have to make sure we're not getting ourselves back into another similar situation. I'm actually a Sedera affiliate. One of the things that's emerging for direct care doctors is actually putting together basically combining Sedera or some other catastrophic coverage with direct care, whether that's, in Houston, we're talking about a bundled surgery group, Texas Free Market Surgery, possibly one of the, there's a chain actually of urgent cares here that also does direct primary care. So putting that in as primary care, green imaging, and then Sedera as the catastrophic, and creating some real ecosystems of great care. So there are all kinds of creative ways we can use this opportunity and momentum to move forward. So I'm really thrilled. It's been a 10-year journey. I enjoy every day of work in this market. I'm not really beholden to anybody, and I can do what I want to. And it's a great way to practice.
Excellent. We're going to start with some questions that I have received from other specialists that are looking into practicing, or they already started to practice. The first question that everybody has is, how can we best define direct specialty care? When we present that to patients, how can we put the words together to make the patients understand what exactly is direct specialty care? And Paula, you can start, and then I'll ask Cristin to join.
So I think that's a great question. So one of the first things people always ask me is like, when I created Uberdoc, it started as surgical specialist. Like that's the easy one because you need a referral, you can skip the referral. So we're looking for convenience, right? So convenience is something patients understand. It's actually interesting. The three biggest drivers of healthcare: convenience, access to care, and cost, transparency, and quality. So quality, cost, and access. So the one thing that patients rank last always, and it's counterintuitive, is in fact quality. It is assumed that we have quality. It is assumed that if you are a doctor, if you have trained and you have studied all these years and you are licensed and you're credentialed and you have hospital privileges, that you are in fact of quality. And it's just very, very important, because I think that when you talk about how do you define this direct pay marketplace, you have to start with the drivers of healthcare. So people choose their airlines, they don't choose their pilots. I think it's very, very important to have confidence. The system has removed our confidence. In the last decade or more, quality is all we ever hear. And quality is never measured based on outcome. It's not measured based on anything real. We fill out all these check boxes. It all depends on how good your system is or how many employees you have. It almost begs the question, right? In other words, the more resources you have, the better quality you have, because that's what they're, quote, measuring. But what you can't measure, what you cannot measure, is the experience, the judgment, the time you spend with a patient. And so I think that one of the things that's our responsibility, and that I'm seeing on, at least on the Uberdocs side, is the first thing we did was we defined what a specialist was. And a specialist is basically all doctors are specialists. You are a specialist in internal medicine. You are a specialist in pediatrics. You are a specialist in neurosurgery. You are a specialist in radiology. Every physician is a specialist. That is first. So I joke about no one on Uberdoc is less than 35 years old, right? Because you have to. So with that definition of specialty care, you're getting an experienced physician. You're not getting relegated necessarily to a mid-level for that triage, right? You're actually getting in the office with the doctor who is specialized in taking care of you with experience. So I think it's very important that we define ourselves, that when we talk about this movement toward direct pay, what does it mean to direct care? That we define that the fact that the care is being provided not by a substitute. There is no middle person. You're actually getting a Navy SEAL. And if you want a Navy SEAL, that's what you're getting with Uberdoc. And that's what you're going to get through this specialty market. If you want to have somebody that is maybe less experienced, you can go in another direction. So this is really, really important, I think, as we as specialists move into this next world of direct pay, which is already here, that we have a very transparent relationship with our patients, that we don't mince words, we take out that middleman, and we show that that's who we are. But we have to be convenient, and we have to be accessible, because the quality, believe it or not, is going to be assumed.
That's true. That's very true. Cristin?
Yeah, and that's people always think that Blue Cross Blue Shield, if you're in the Blue Cross Blue Shield network, that must mean something. No, they take just about everybody. But we do. So I do think that that actually we do have to talk about what is quality in medicine. All the things that have been put out there, the MIPS and those things are the patient experience. With American College of Radiology, 95% of how a patient rates their experience with an imaging study is how they were treated in the imaging center. They don't care if it's an open MRI versus a 1.5. They don't care about those things. They really care about how they're treated. So it's not only the patients, the physicians, experience and knowledge base. It's also how they're treated. And, I think we were so tied down by bureaucracy for so long that we lost touch with how to really treat patients. And when you remove a lot of the bureaucracy, all these HIPAA forms and all these things that patients have to deal with before they even see us, when we get rid of all those layers of bureaucracy, we're able to focus on the patient. And I'm from a multi-specialty background. Doctors, discussing, we would sit down at lunch and discuss cases, with 3 or 4 specialists, sitting there and weighing in, that's great medical care. And what I can do now on my platform, what technology is allowing us to do, I can not only, if I have, I know a patient has a contrast allergy, I can ask the patient questions right then. They go to them as a text and gather that information. If a referring physician has a question about what something means on a report, I can tell them that, and then I can send them an image, with big, the big circle around the tumor, and show them exactly what I'm talking about. So I think when we get rid of bureaucracy and add technology, we can really add to communication. And I think that's one of the great opportunities here in this space, especially in the independent physician space, where we're not in big hospital systems with all the rules and red tape. We can create this market, and we can do things that make it a lot easier for patients to get care and make it a lot more affordable for patients to get care.
I agree. Another very often question that I got was regarding how to determine a fair price for our services. As you know, we as physicians have no idea what is behind the contracts that our institution has with the insurance companies, and we do not know how much we are supposed to be paid. So a lot of us, we have a big problem when it comes to a reference point. Do you have any recommendations about how to determine a fair price for the services that we provide? Because that was lost over the years.
So, so this is something that we took this challenge for Uberdoc at the very beginning. We had to decide what was going to be our price point, right? We wanted to put a single price point out for an office visit with a specialist. So we looked at, our reference point was Medicare, what the Medicare allowable was going to be for an E&M4, E&M5, visit. And we took it at kind of the highest levels, and we priced above it because you can't price below it. Many doctors may not be aware, but if you price below Medicare, you're not Medicare compliant. So we put our price point high enough above Medicare to be compliant and fair, but below commercial insurance, because we felt that, you know, you wanted to make it affordable, and you also didn't have the overhead involved in collecting the money, right? You didn't have to have the multiple layers of authorization, this, that, the other thing, and you didn't have to pay a billing service and so forth. So that's how we really thought about this. Our original price point was $300, and then during COVID, we dropped it to $250 because the economy shrunk. And we looked at all the data that was out there. We were informed by people who were in, you know, looking at claims data, looking at the actual what people were paying for care and what their salaries were, and we shrunk the price point. Now we allow doctors to kind of set their price point. It can't go below $150. We are not a race to the bottom. We do not think that's a good idea. There's a lot of people out there that will price like a telemedicine appointment very low, $39, and you can get, I think on Sesame, you can actually get you can get your IUD removed, and you can get an anxiety pill or something. It's like, we are not a race to the bottom. I think that's a problem. I think we put it as high as 500 because there are people that are super highly specialized that may be doing some consultative work or second opinion work. You know, we did that based on the economics. We did studies, and we did it at the reference points of Medicare. I think that is where you need to live if you're going to be in a cash model, because I think if you price yourself way high, you're probably not going to get patients. But you cannot price yourself low for compliance reasons, and also it will, you know, ultimately, you know, you can always, you know, work for some of these companies where they're paying you. I think HIMSS pays based on a prorated hour, and it can be like, you know, as low as like $18 or something. It's like, so you really have to ask yourself, is that worth your time? You might as well just do it for free or not do it at all. So so I do think the price is very important. You can't be too low, and you can't be too high. Reference point around Medicare, at least again, we're setting for an E&M code. Now that being said, Uberdoc is not setting the price for anything else, but we set the transparency. So our great hope is that as we expand our network, and we have begun with imaging and with blood tests and with prescriptions, that the Uberdoc account will stand for transparency, so that we don't set the price. If a surgery center wanted to do a colonoscopy and say, just put it on my Uberdoc account, you know, go through my Uberdoc, you're not going to have to negotiate that price. It'll be a transparent price, but it's set to that particular place. It's too hard to set prices across the country. Price in Texas versus Boston is way different. But we can set and demand the transparency. So at least a patient knows that they're going to get something reference point to that Medicare price that's slightly higher. And whether it's 1.5, 1.25 Medicare, and that pretty much should, you know, is where most of us are priced anyways in terms of our insurance contracts that are independent outside of facility fees and so forth.
That's very good. Cristin, do you have any recommendations?
Yeah, this is something that I've worked very hard on. You know, imaging, the reference base for imaging is horrible. We've taken 10% decreases 3 years in a row to offset increases in E&M, while our expenses have gone up dramatically. I think $237 is now a knee MRI reimbursement in an outpatient imaging center in Houston, and nobody can put in a $1.5 million machine into a $750,000 room and, you know, make that math work. So, you know, I've been very strong and verbal about, you know, making sure that we have sustainable pricing. This has to be, you know, so that the imaging centers can replace the magnet every 10 years if needed, or afford the AI software that can upgrade the magnet. You know, this, and then the other thing, like that Paula spoke to, and I'm going to talk about some resources for physicians who are looking, you know, at the direct care model. But, you know, the Free Market Medical Association emphasizes that, number one, you know, why is it that a young orthopedist straight out of, you know, his residency gets paid the same by Blue Cross Blue Shield as, you know, a 30-year experienced doctor? Makes no sense. You know, why would a doctor in Houston get paid the same as somebody in Boston? Makes no sense. You know, there are market forces here. And so you do have to be very careful and methodical in your pricing. A formula to remember is that doctors spend about 30% of what they're contracted they spend about 30% of their revenue to collect 70% of what they're contracted to receive from health insurance companies. And so if you apply that model, you can see you can take a discount from your insurance reimbursement and still do well with cash rates. I'm going to recommend everybody look into the Free Market Medical Association. They have great resources for physicians and great learning opportunities for physicians who want to launch direct care practices. I think Marshall Allen's book that's coming out this summer, Tony Dale's book that's coming out this summer, Marty Makari's The Price We Pay are all great resources. They all should be assigned reading. And then also Dave Chase's Health Rosetta has some really interesting webinars and educational pieces. And these are just, resources that have helped me along the way on my path to both understanding what is so broken in the system and, understanding how to go about, creating a new way to provide care, a new and better way to provide care. And I will say, Paula, that, I am intentionally not a CMS provider. That releases you from lots and lots of bureaucracy, like not being able to price yourself less than Medicare. You're not a CMS provider, that's not in there. So, do think very carefully about whether or not you want to continue to do that, because it does tie your hands in some direct care arrangements.
Right, I think that's a very good point. I think that in terms of, moving from a model where you're taking insurance into a direct pay model is kind of a scary move. And one of the things that we like about our model is that we allow doctors to kind of dip their toe into it so that they don't have to necessarily give up all of their panels in order to have direct pay. I do believe this is a consumer-driven market. And that third piece of the pie, that direct pay piece, is only getting bigger because of not just the way employers are handling insurance, but the fact that we have remote workers. You can't possibly control cost in a network when your employees are deployed across every time zone and every economic. So it makes it almost impossible, right, to have an employee health plan that would make sense. So this is like just such a golden opportunity to again offer this new option for patients. But I do think there's no question Medicare, unfortunately, I say that because over the last decade, it's gotten more and more complicated. The overhead for a Medicare patient, even on the government side, has escalated beyond. It used to be 5 cents on the dollar. Now I think it's like 35 cents on the dollar that they're wasting. And it's a pity because, again, the government entanglements have only complicated and raised the cost for everyone.
And I would also add that I think we have a generational opportunity. I watched my 26-year-old son who has a traditional insurance policy. He's paying out of pocket for direct primary care, for subscription-based primary care. He went and got physical therapy, paid for it out of pocket. They are a consumer, they're a consumer generation and not, tied to traditional healthcare, what we call traditional healthcare. And so I think we have a great opportunity with young people.
Well, that's very true. I'm going to move along to the next question because there are many questions coming in the chat. Some of them are already in my list. The other question is, how should a specialist start as a hybrid model versus a strict direct care model? We are all trying to get away from the fee-for-service. We are interested to incorporate membership models, but we don't have any way of, that's the difficulty that we have. We don't know how to base our membership models. We look at the direct primary care models, and we love the fact that they figure it out. But for our specialties that will involve chronic management, especially like endocrinology, rheumatology, and I'm just naming a few, where patients do require chronic management, how would that be? What would that be a better approach? Start as a hybrid and then move towards membership, or just go fee for serving and then move towards membership? I know you might not have experience with that, but do you have a thought?
Absolutely. I think that it really, when you think of this different specialties, right, you have people that will manage their own patients indefinitely, and then you have people that will be a one-off, right? You twist your ankle once, you don't need an orthopedic forever, right? But then you have a joint issue, you do need an orthopedic forever, right? So I think that a lot, we have to look at your practice, and if you are someone that can, if you know, the primary cares have that advantage that they can have a panel, and they can complete their panel, and they can know that they're going to collect X amount of dollars from everybody, and that's your economics. But specialists don't have that luxury. You don't know, unless you have, again, that a really well-established chronic patient panel that you've been following for years. But even in that sense, you still need new patients to come in. So I think that in the specialty model, you keep the cash lane open for new patients that come into your system. You attract new patients because of your talent, because of what you're offering. They get to you quickly. If they proceed with you with insurance, it depends. If you take their insurance or not, then that becomes that could become a contract that you make with the patient. I think to survive economically, you have to be flexible. And especially as a specialist, and if you do surgical procedures, it's very hard. They can pay your fee, but are they going to be able to pay the fee for the surgeon center, the anesthesia, the pathology, and everything else that comes along with doing your surgery? So you can decide a contract with that patient individually for your fee, but you can't set the price for everything along the way. And that's asking a lot for you to do as a doctor. So I think that that a hybrid model makes sense. I think that the access points, again, I always use this analogy: do you need to use your car insurance for an oil change? Patients will also kind of think that way and say, well, gosh, going to a specialist, I could just, is like, going to an office visit, an oil change. But when I need to have, like, when I smash my car and have an accident, I need the hospital, that's when you use your insurance. So I think that, again, it's almost like you follow the consumer in this case. You have to really think about that consumer in terms of what they're thinking, what their health plans look like, how they access care. Be front and center. I couldn't agree more with Cristin about, we have a golden opportunity with the young people, for they like convenience, they like access, they like pushing buttons. We can be right in front of them. If that person finds a gynecologist through a direct pay model, but then has a baby, that is where that hybrid model really is important, because the last thing you want to do is create a relationship and not be able to continue it. So I do think it's based on specialty. And if you are, you have a panel of people and you have chronic disease, you're going to want to follow those patients. A lot of them have to buy their medications. They aren't necessarily going to have a cash model for that. They might have a very good, they're paying extra through their employer for a prescription plan. So you have to be flexible, because you have to be successful economically to be able to, stay in practice. And I think that it's very, very hard right now to narrow your focus to that point, unless you have like really well-established relationships. And I think that, again, from a specialty standpoint, you want to kind of move with the consumer.
And I agree. I certainly have been hybrid along the way. In fact, I only went full-time with green imaging a year ago. And thank goodness I did prior to the pandemic. But, we started out with green imaging, grew our radiology practice much more quickly than we grew our direct contracting, because we were actually taking patients to these imaging centers. They were used to the radiologist sitting in the back room with the lights off reading films. And so instead we were bringing them a referral source. So, we grew that. There's so many opportunities that you can find along the way. I do believe that you have to find aggregators to be, to really be successful in this. You need to find ways to present your practice in multiple, on multiple platforms, whether that's going through the FMMA and meeting some of the TPAs that are there. It's putting yourself out on Uberdocs. It's finding local TPAs or local, just even local large employers. Some of these near site clinics are hiring specialists. There's so many different creative ways to aggregate your services and get them out there. One-offs with patients are very expensive. Whether it's a radio ad, those things, we tried that for a long time just to be a self-pay network, and it's very difficult to get that momentum that way. You've got to, I really feel like, to be super successful in this, you need to find aggregators and get yourself out there. And I think for this movement to work, we have to do that. I think we have to pull together. I think if we try to do it individually, there are a lot of direct primary care doctors who are, very much that the relationship should be between, the patient and the doctor, and no employer or anybody else should be involved. That's great, but that's not going anywhere anytime soon on a large scale. And if we want this really to work, and if we want people, employers to get down the cost of care so they can provide wage increases, if we want to change this paradigm, create a real paradigm shift in American healthcare, we've got to pull together, and we've got to aggregate, and we got to find which of these guys are good guys that are aggregating and which of them aren't, which of them don't care about quality, which of them, it's all about the profit and about the next flip to another private equity group. All of those things we need to be aware of as we go on this journey. But I definitely think it's very, in my experience, we really kind of made it once we got into direct contracting. Once we were able to pull into TPAs and employers, that just switched everything over for us. It enabled us to create great workflows in geographic areas. It just changed everything. I could use those lives to leverage prices with imaging centers. And so, I do believe a hybrid model is frequently needed. But I can say, it was a 10-year journey for me. We're out of there. We're not, there's no CMS, there's no traditional health plans. We are in some innovative health plans, and we were looking at creating our own health plans. So, the sky's the limit once you get going with this. I saw Dr. Bowden is on here, Mary Talley Bowden. She's created an incredible ENT practice that's all about, she still does surgery, but she's all about keeping you away from surgery. And, all these alternative and holistic means of doing so. So, people are out here just being creative and finding new ways to practice. And I think it'll just open your eyes when you start thinking about this. How do I bundle this? How do I get this out there, in the employer healthcare space, or, they're one of these marketplaces? There are a number of marketplaces, and some of them are really, have the same values we do, like the FMMA's marketplace. So I think the opportunities are great. And what we find is that all of, the people who are really trying to do this for the right reason, we all try to work synergistically. We're not competing against each other. Our competition is people who are doing traditional healthcare, who are still doing, going, where's the most expensive MRI? It's down the hall at your doctor's, at your hospital-based doctor's office. And people don't even know that they can say no to their doctor and go somewhere else. So, I think we all have to pull together in this. But I do think that a hybrid model makes sense. It's a lot more secure than going out there and just throwing yourself, to the self-pay patients. That's a pretty rocky road.
And I just wanted to add that, Cristin's exactly right about those aggregators. And that's something that we're now pushing with the Uberdoc. And very early on in our model, it was employee benefit brokers that discovered us. And they discovered us for a couple of reasons. One of them, of course, is that, it's a guaranteed price, for specialty access, and it's convenient. But more importantly, it's off the grid. So that means that when an employer contracts with insurers every year, there's something built into Obamacare called dollar loss ratio, where if the employer had very healthy employees and didn't utilize, you got money back. Now, of course, the insurance company defines utilization by encounter. So you could have like 100 or 200 minor encounters, or you could have 100 liver transplants. It would be the same, right? Well, there's a kind of ratio that goes in there, but the encounters count. So the fact that you could take a certain percentage of your visits off the grid, right? You get your imaging, the patient's paying for it. You go to a specialist, the patient's paying for it, means that the encounter is not generated. So it's very interesting because it's kind of counter to everything that we think about in these employer plans. But they were like, you build it, we will come. So we built it, and now we have a heat map all over the country where our doctors are, and reaching out to employers now to say, hey, we built it. You know, bring them on in, bring them in, you know, because then those employers, those employees that are in these employer-based plans have some freedom to take their health savings account and go find a direct pay option that will be good for them, better outcome, they'll be happy. And that's all that employers kind of want, is they don't even want to deal with healthcare, right? They become health providers almost. They don't even want to honestly deal with their employees, dealing with, you know, navigating their healthcare employees. So I just think that that's a very interesting opportunity that we have. Also, we have the ear of many employers who are looking for something better. Oh, you're muted, Diana.
So I have to make a few comments here. Taking just the direct care practice road, it's very tricky. I am there, and I have been growing, but the growing is slow. However, more and more patients are looking for opportunities to get the right care that they need. And they also appreciate the fact that you offer transparent prices, which are right there, are not estimated prices, because what we see at this point on the majority of the big hospitals' websites, it's an estimated price, which is not even close to what you're gonna get. But I'm going to give the opportunity to people to ask their questions. I have Christopher Habig that wants to ask a question, and then I have Hema that wants to ask a question. Christopher.
Hey, Diana, thanks. This has been great. I'm curious about the feedback that you know, specialists are getting from primary care doctors, specifically direct primary care doctors who think, oh, specialists aren't hurting, they're not going to want to go into the cash model. What's the reaction been from those DPC physicians when you say, yeah, we are in pain here, we have a lot of hurt, we want to go into cash, help us do this?
We are there at building bridges, Chris. We have me and Lou and Lara, and there are a few other people here on the call. We have been, and Ellen, and let me see who other people are here. So we, the specialists, we started to build bridges with the DPC community. And we've been giving lectures, free lectures to the DPC community. They appreciate that, and they started to say that they are sick of you know, certain platforms that will just offer them a very strict answer to their questions. They are open to the peer-to-peer collaboration where they can pick up the phone and call a physician and have their answer ready. So I think the DPC community has to come and help us, and we are very happy to, you know, kind of pair with them to provide the help that they were in need for many years. I would let the others to comment as well.
I was just going to add that, you know, so we started, Chris, as a, you know, as a specialty, kind of work around the primaries. Within a year and a half, they joined us. It's like we're all in the same boat. Whether misery loves company, it's been a wonderful unifying experience, because we're transcending what the insurers really created, which was this kind of fake world of like, oh, the specialists are making more money. Oh, you have to do this, and you know, and pass the patient around and manage care. It's like all that is fake, right? We know that none of that was really beneficial to patients, right? It was just, you know, servicing the insurers. So once we kind of figured that out, the other thing is DPC doctors are sometimes excluded from networks. Like, in other words, a DPC doctor in a community can't generate a referral to a surgeon who is it because they're not network, and then the patient has to go find a primary that's a network. I mean, all this nonsense. And luckily, I think network restrictions are kind of peeling back in some of the new legislation indirectly. But it really was a problem. so we reached out to the DPC world, and in fact, that's one of the things that, I mean, they're big fans of Uberdoc because we support them, but they also, our specialists are going to provide care for their patients, so that they say, well, the patient came to me looking for a direct pay option for primary care. Can they find a specialist that can be also offering that same transparency? And I think that this is, again, this is a perfect opportunity for all of us to kind of come together. Once again, all doctors are specialists, right? If you think of it that way, we are literally in the same bucket.
And my background is multi-specialty groups. I practiced until last year with multi-specialty groups exclusively. And I do think that that's the best care. And we did treat our primary care doctors as specialists in that setting. And I do think that that's the best care when we're all collaborating, when we have good communication tools between us. And we all of our incentives are aligned. I love the model of a DPC doctor attending the consult, but a telehealth consult between the other specialist or the subspecialist and the patient, with a three-party interaction, because the patient doesn't always get, all the information isn't always conveyed by the patient that needs to be there. And so I think that's a great model.
I agree. Hema wants to ask a question. Thank you, Chris, for your question.
Oh, hi. Thank you for doing this. I'm a GYN. I have my own practice for the 4 years. I do GYN with the major surgery. And I live in an area where I'm surrounded by a big healthcare institutions and good insurance coverage patients. But I'm really interested in doing direct care because of all the insurance contracts. They pay much less to being a solo practitioner. And all the paperwork that comes with it. So one of the doctors, Dr. Muto or Dr. Dickerson, mentioned that we actually solo practitioner, or we as a private practice physicians, we cost much less to the system as opposed to employed physicians. I'm having trouble explaining that to the patients. They don't care as long as insurance pays, whether it's 3 times or 1 time. So how do you convert them into direct pay patients? And also, as a pioneering entrepreneurs in this field, do you have any resources for newbies like me in terms of like any brochures to the patients or website like reconstruction saying that, okay, this is what direct specialty care is. These are the advantages. So we don't have to reinvent the wheel, which you already worked on. Are you thinking of like convincing the patients how like we are beneficial to you?
We are building that part, the education of the patient. We are working on building up that part. But I will let Dr. Muto and Dr. Dickerson to join and answer your question.
So I think that, again, you do something well. You want to you want more patients to find you because you can solve that problem so quickly, right? That's what it comes down to, right? And so taking away all the obstacles, and how do you get out there to the patient? So I think that when you think about educating your patient, you kind of have to get in front of them somehow, right? And there is a marketing component to all of this, and because you can't. None of us here we wouldn't be here if we relied solely on our referral pattern, right? Because the referral patterns cross so many times. And yes, we could all go work for a hospital, but there's still RVUs, right? So I always like to think that every doctor is actually a private practice doctor, whether they're housed in a hospital or independent, they're the same, right? Our entire world is a peer-to-peer transaction, right? We judge ourselves by how many patients we have in our waiting room, right? I mean, that's how we value ourselves. So everybody is competitive, and everybody wants to kind of get in front of the patient. I think that that you have to be very you got to learn about marketing. I've been marketing my vein practice for 15 years. I got consultants that took money, other consultants that did really great work. Marketing has changed, right? It used to be you took an ad in the newspaper, then you do those magazines, and they're like, oh no, now it's online, and now it changes, and now I have a company, Uberdocs, and believe me, this is what we do for a living, is market practices. In fact, tomorrow night we're having a whole session with my marketing team, teaching doctors how to market their practice. I was very resentful that I hired like website managers who took a ton of money from me to make me quote the top of Google. When I found that my website was occupied by a male radiologist from New Jersey, I'm like, time out, guys, that's not me, and yet I'm paying you. So there's a lot of stuff out there that take a lot of money from doctors' pockets, right? Because they're predatory practices. It's one of the other motivations behind Uberdoc is that I don't even charge my doctors to be on the platform. I just want your seat in the waiting room, because the marketing is up to me, because I didn't want to make my doctors pay thousands of dollars for marketing, right? I mean, because marketing is and that's my job, right? If we're all on the same platform, we can put it all together. So I have to say that marketing your practice to patients is very important. And so it's the entrepreneurial spirit, it's the independent doctor, it's who we are as specialists. You want to peddle your wares directly to that patient and let them know who you are. And I think that that there are the answer to marketing, and my marketing team will be laughing because it changes almost on a daily basis how you get in front of people, especially with the internet and everything else. And you can go broke very quickly. So I would say that what we had said before, together, we are so much stronger than we are apart. And that's kind of, the vision that I see is that, patients ultimately are going to find you because you are good, but you're also local and you're convenient, and they found you, right? And you're responsive. And that's how they're going to meet with you. And then that is going to be your patient. Then the old-fashioned medicine, they tell their friends, they tell their family, right? And as long as you are accessible and you transcend any network restriction, in other words, they can find you, but I don't have that insurance. Does she take my insurance? Hey, she takes cash. What better than that, right? And really, is she expensive? Nope, she's transparent. So like, this is how it's all going to happen, right? And it's going to happen through that direct to consumer marketing world.
And I would also emphasize, I have so many patients who have good insurance who just use us because it's easier. They'd rather go pay the $400 for the MRI and go drive up to one of our imaging centers than go through the pre-auth, all the paperwork, the insurance, the EOB, the surprise bill, everything else that goes with working with a hospital system. And, the ease of use. I mean, there's no wait, we'll find them an imaging center, they'll go. It's not this, next 2 Thursdays from now at, 9 a.m, worst traffic time, whatever it is, ease of use creates its own market. And, I do think that with the financial end of things also, patients don't realize how much they spend out of their own pocket for healthcare, even with quote unquote good insurance. They have their portion of the premium, a significant portion of the time. They've got the deductible. They frequently have co-insurance. The contracted rates are actually higher than the cash rates. So they're paying, more of a percentage. They're also keeping themselves from getting wage increases because they're spending their employers' discretionary money on unneeded healthcare or very expensive healthcare. So I think having a blog and really getting those informational pieces out there is another way to communicate with employees. Getting on Facebook, getting on LinkedIn hashtag healthcare. You'll find some really some good thought leaders there that can teach you a whole lot about what's going on with healthcare plans and especially employer-sponsored health care, and a lot of good aggregators and a lot of thought leaders and a lot of people who are talking about how we get to Bitcoin and do a lot of very interesting things that can happen in this less bureaucratic market.
I'm so excited that there are so many people here and there is so much interest towards direct care. I have so many other questions. I think we need a couple of more sessions to answer all the questions, but I think this is the beginning. And as Dr. Paula Muto said, we are and we have to be united. If you are interested in this movement, you have to come along us and support us and help us. We are actively trying to build a network of specialists, to present ourselves in front of the employers, to present ourselves in front of these telemedicine platforms. I think the fact that we are interested, it's a huge step to go ahead. We have many hurdles against us. We have many things that we need to figure out. But I think that with support and with perseverance, we will get there. It is in our best interest, and it is in the patient interest. Why did you all get into medicine? I think that we have the same thought. We wanted to take care of the patients. We did not want it to be in productivity models. We wanted to serve the patient, and we wanted to be respected as well as physicians. And I think we are facing a movement towards physicians. We are blamed for many things that is not our fault. But I want to thank everybody that took the time to come here and ask their questions, and the people that couldn't be here, but they send me questions. I'm going to share the recording with all of you, and I'm going to ask Dr. Paula Muto and Dr. Cristin Dickerson to offer a short piece of advice to people that are considering to go into direct care or do a hybrid model. But be open, be transparent, be affordable, and come back and practice medicine again. And I want to thank them from the bottom of my heart for taking the time to educate us. They are very important and very busy persons. Thank you, ladies. And thank you, everyone. And just a short piece of advice.
So first I want to thank you, Diana, exceptional doctor. She kind of sets the bar for what a doctor should be in the digital health world. She's the future. So the only advice I give is that, we have to do what you're trained to do, right? Do what you're trained to do. And when you find that you're not, we got to find a way to make it work. And it's very empowering to be able to just do what's right for the patient and not be handcuffed by the steps that we have to take from an arbitrary insurance person who decides you have to take 5 steps instead of 1. And I should say, be courageous. You can stand up to the system. There are other options. To stay as a future doctor, you need to open up that aisle for cash pay, and just see and not be afraid to do it. There's no restriction to it. It's empowering. It's free to. You're able to go directly to your patient. And I would also advise, tell your patients that you already have, it's okay to go direct to me. Put those appointment slots out there and say, you want to skip the line? Just come in this door and you pay me cash. And that's totally fair. Instead of, I can't see you for 3 months, be available, be convenient, be transparent.
Yeah, and I'm going to say, I really think, number one, get involved with an organization like Free Market Medical Association. I think their meeting is in August this year in person in Dallas. That's definitely a game changer, because the educational resources, you come to understand the economics of medicine by doing that. So I think that's definitely, I think courage is so important. I doubled my staff during the pandemic. That I can't tell you, how many times I just had to take a deep breath and dive in and do that. It does take that, but the payoff is tremendous. And the other thing I'm going to say is explore Sedera. Take a look at what they're doing. And Tony Dale's book is coming out this summer. He's the founder of Sedera. And, he thinks about things. It's an entirely different way to think about providing and paying for medical care. I think it can be a game changer for your practice. If you educate your patients, your existing insurance patients about Sedera, they can save 30 to 50% on their healthcare coverage. And you're not only providing them better direct care, but they're also getting something tremendous from you. That my family, my husband and I have saved probably $100,000 in 5 years, just changing the model by which we get healthcare. And so I think you also have to be willing to get out there and do it yourself. You've got to live it too. If you expect your patients to do it, you've got to live it.
I agree. Before we close the meeting, once again, thank you everyone that participated to this meeting. I want to say that before I dive into direct care model, I had no idea about Sedera. I had no idea about Health Rosetta. And I read all the books that were cited here. And I'm more than happy to share the names of the books with everybody. Once again, have a wonderful evening. And we should clap for these lovely ladies that took the time to come here.
Thanks for doing this, Deanna.
Thank you so much,
Take care,
everyone.
everybody.
Thank you.